Brennan, who's coming to us from Washington University in St. Louis. Dr. Brennan received his BA from Cornell College in Iowa and his MD from the University of Iowa. He then went on to the Brigham and Women's and received his residency and fellowship training there. He's what I would classify as a very accomplished academician, accomplished in research, clinical studies, excellent patient care, and fantastic education of rising people like me. And he's one of my favorite people. So please join me in welcoming him today.
Thank you, Angelina, for having me, Greg, and everyone to be here. I was saying, I think I was here a while ago, about 3, 4, 5 years ago, I can't remember. But at any rate, it's great to be back. Didn't make it to the Riverwalk, but had a wonderful time with one of my other former fellows, Irfan Aga, who's over at Methodist on the other side. So at any rate, it's really good to be here. So these are some of my disclosures and financial relationships. Fortunately, I have some, and it allows me to keep going. So the KDIGO, Clinical Practice Guideline for the Care of the Transplant, says a summary of what to do with induction therapy. And the KDIGO guidelines they recommend that the induction therapy with a biological part of the initial immunosuppressive regimen in basically all kidney transplant recipients. There's some of that I don't disagree with. So for instance, we do not use induction therapy in our 2 haplotype matched living-related Caucasian patients, but we do in everyone else. And part of that, with that, we also withdraw the calcineurin inhibitors starting at about 6 months or so. So KDIGO recommends that an IL-2 receptor antagonist be used for first-line induction therapy. That's a 1B recommendation. I don't agree with that, and I'll show you the data why. And they suggest a lymphocyte depleting agent rather than an IL-2 receptor blocker for kidney transplants at high immunological risk. We'll talk about what high immunologic risk is. So it reminds me of when I was in med school, and they were we had an ID doctor talking about infections. You know, is strep pneumonia a serious bacterial infection? Well, you know, if you happen to be Jim Henson, it is, right? You know, I mean, he ended up dying of it. Is gonorrhea a serious infection? Not in a patient that you're treating, probably, but if you come home from a business trip with it, it's a serious infection. So when you look, this is the last official SRTR data published in 2012 with data really through 2011. What's important is we all talk about there not being enough kidneys, that there's an unavailability, but you also have to think about, you know, maybe we have not only, we have a listing glut too. And because look at that, when you look at this, the active new patients that are added there's 20,000 people added, but when you look at the inactive, half of those are inactive. So we'll go over some of the reasons why that is. And when you look at the list, there was, 55,000 that were active, but 35,000, more than half of, them are actually inactive. So what are we doing? And in terms of who we're listing, and so how do you tell who you should list? We'll look at that. One of the other things that's happened is everyone has talked about the fact that the acute rejection has dramatically decreased over time. Part of that's going to be, I think, because of induction therapy. Part of it's going to be because of the introduction of the Banff criteria in 1993. So the Banff criteria ended up having something that we all used, because before it was blue cells are bad, blue cells are still bad, but actually that was what it was, and that a lot of people came from Minnesota, big transplant center, and they had a grading of 1 to 5. But some of that was just a venulitis, and they called that a rejection. It probably was CMV infection. Any rate, you can see that rejection rates when I first started around at the time at WashU were running 40 to 50%. Now, the other thing to pay attention to is we talk about high risk. Well, what determines that? Is that the rejection rate? Well, pretty similar rejection rates between living donor and deceased donors. So maybe living donors are pretty high risk. And remember, that's including that they're better HLA matched. So what you have is maybe living donors, just something to think about, aren't as low risk as you'd like to believe. So there tend to be three phases of immunosuppression. One is induction therapy, that's what we're talking about today, and then maintenance and the adjustment of that. This is a cartoon I drew when I had little kids. So I had my little kids' cartoons and drawings all over my office, and so I had to compete, and not really, but this is what I came up with. And so I still like it. It's old, but what it shows on the top here is an antigen-presenting cell, presenting antigen in the center with MHC class 1 or 2 to the T-cell receptor along with the CD3 complex. The CD3 complex is, I listed all the things that they have there, gamma, delta, epsilon, zeta, eta. It was really more eta, eta is probably what you got. At any rate, OKT3, for those of you who are old enough to remember it, targeted the epsilon subunit of that, and it would basically make the T-cell receptor internalize, and you couldn't see it, and you couldn't see CD3. Then there's secondary molecules, CD2, which has become really important. That was one of the major secondary signaling pathways. Now, why do we know it? Because it's important for proteinuria. Who would have thought? But Andre Shaw at WashU ended up discovering this, and now people talk about that. And then there are secondary signal molecules, CD5, which is on B cells a lot, so that's important. LFA1 and ICAM, so lymphocyte functioning antigen and intracellular adhesion molecule. So what's important there is ICAM is actually the receptor for the common cold virus. So there is actually a drug for it. It's a nasal spray, and it reduces the duration of your common cold symptoms from 7 days down to about 1 week. So that's why it hasn't made a much penetration in the market. So, but at any rate, there are things that target that. And then now you've got CD40. Look what's happening with CD40. You know, it's a CD40 ligand, CTLA4, belatacept, and the B7, 1 and 2, CD45. So these are things that suggest that the immune system there is, to review, polymolecular, all kinds of different antigens, polycellular, and when I came to WashU, we're trying to figure out with Wayne Fly, what kind of immunosuppression are we going to use? They're having a lot of problems at the time. So these are some of the immunosuppressive. On the upper left is the anti-receptor antibodies, ATGAM, which is a horse antibody, thymoglobulin, OKT3, anti-IL-2 receptor, which is humanized, and that was Basiliximab, which is Simulect, and Daclizumab, Zenapax, which is no longer available, Alemtuzumab, which is Campath, anti-CD52, belatacept, rituximab has been used, eculizumab, the IDX anti-CD40 ligand, that's gone away because it caused a lot of problems with increased risk of thrombosis, but it's coming back again. I'm not going to talk really about the rest of the other things used as induction therapy today. So this is the cartoon, similar to my cartoon, but a little bit more detailed, that was produced by Phil Halloran from Edmonton in the New England Journal. Same concept in green in the upper left. You got an antigen-presenting cell presenting antigen, and then that's to the T cell in blue, and that is signal 1. Then you've got signal 2, which is the co-stimulatory signals that you get. CD80, 86 is B71 and B72. CD28 is CTLA4, so they ended up going on. Then you've got signal 3, which is the proliferation signals. Then what you've got in the boxes is all the drugs and where they work and how some have come and gone. So for instance, there's azathioprine, probably my favorite drug, and there's now a shortage in the United States, which I think I'm personally responsible for, and it's just a great drug. FTY 720, that's gone. Anti-CD52 Campath, FK778 was a leflunomide derivative. So just showing you a little bit where some of these drugs are and where they work. But again, what it points out is the immune system is very redundant. So does it make sense that we could target one single antigen and get control of the immune system? No, and in many ways that's good, because otherwise bacteria, viruses would figure out a way to get around it. So the polyclonal antibodies that are available in the United States are the horse polyclonal antibody, which is ATGAM, and the rabbit polyclonal antibody, which is thymoglobulin. In Europe, they have something called Fresenius. So what's the difference? Well, first of all, it's potency on a milligram per kilogram basis. So ATGAM, the normal dose, is about 15 milligrams per kilogram. Thymoglobulin, the dose is about 1/10 of what you give with ATGAM, and then Fresenius ATG is in between. So you have to understand how these drugs were made. Basically what they did was they took lymphocytes from, in the case of ATGAM, and then they injected them into horses, and then the horses, they gave them something called Freund's adjuvant to make them rev up the immune system, and then they bled the horses and then purified the product, and they came up with ATGAM, and that was produced by Upjohn and then Pfizer, but it really started out basically in the backyard of the farm of Ben Cosme, one of the surgeon at the MGH. Thymoglobulin started in France, and what they did is they took thymuses from little kids who were getting open heart surgery, and they took the thymus, ground it up, injected into rabbits, lots of rabbits. And actually these rabbits, if you see them, they're like huge rabbits. They're like, Monty Python, Holy Grail type rabbits, and they're just gigantic. Then they would bleed them, purify it, etc. So, and then the Fresenius ATG, the immunogen is actually the Jurkat T cell line. Anyone know about the Jurkat T cell line? It's a leukemia line. That's a little scary, but at any rate, so they take this, and the idea you would think is that since it's a T cell line, that it would be stable, and you wouldn't have all this concern with the different rabbits, the different horses and everything. Well, in fact, if anyone's worked with cell culture and you have a T cell line, the antigens on it are always changing. So it turns out that it's not quite as stable as you'd like to think. So some of the side effects are rash, and with ATGAM, you're supposed to give a test dose to them, a subcutaneous test dose. It's not in the thymo package insert, which is great. You could have a cytokine release syndrome, and in fact, about 50% of patients getting these develop a fever. Usually, there's nothing to it, but and we don't even culture up or do anything. So, 50% get it. You can get leukopenia, thrombocytopenia are common. PTLD is uncommon. There is an increased risk of CMV infection. I'll talk about that a little bit. And serum sickness. So serum sickness, we did a study and showed up that it turns out that if you've had exposure to rabbits, which turns 50% of people in Missouri eat rabbits, hunt rabbits, raise rabbits, and I get this rabbit fetish thing. And so so that they're a little bit more prone, but it's so rare that you don't not give the thymoglobulin. But the key features, I was telling Greg, are myalgias, severe myalgias, about 7 to 10 days after they got the thymoglobulin or whatever, and a jaw pain. That's like classic. So then this also brings up that serum sickness is more common if you've had prior exposure. So if you give thymoglobulin for a second transplant after you've used it for induction or rejection. But you can usually get away with it. It's a little bit more common, but not that much. The mechanisms of the polyclonal agents are T and B cell depletion, T and B cell depletion, okay? Remember, for years we've lived under what I like to say the tyranny of the T cell, and now we got the B cell, and the B cell is bad, except when it's not, when it's a tolerogenic profile. So this is human transplant immunology. So co-stimulation, blockade, inhibition of antibody-dependent cellular cytotoxicity, and that should be induction of apoptosis. So multi-mechanisms to try and control things, and we probably don't know all the mechanisms. One of the things, I'll show you some of the data that we did in some of these studies, but one of the things when Wayne Fly and I were first coming up with our immunosuppressive regimen when I got there, he was a surgeon, one of the early surgeons, and we thought that you really should try and get control of the immune system before the horse got out of the barn. So at that time, we were using ATGAM, which is a horse preparation. So no, at any rate. So what happened was we decided that before the rubber met the road, where the lymphocyte met the endothelium, we should be blocking that interaction. And we should be given the ATGAM at the time in the operating room. There's another reason we were doing that. OKT3 had a horrible cytokine release syndrome, a shake and bake. Fevers of 103, aseptic meningitis, pulmonary edema. It was a drug we loved to hate. So what happened was we started giving, and others gave it in the OR because they're intubated, you had the control of the airway. And I said, why don't we give the ATGAM in the OR 2. That's what makes sense because everyone was given it the day after or the night after. And I said, besides that, it might even get them out of the hospital a day early. And wouldn't the hospital administrators love us because of that? Well, you know, they never love you. But at any rate, so what happens, we ended up doing that. And there was a guy in Germany who did an interesting study. He took a monkey, and he took blood from the monkey and incubated the monkey blood with either saline, control there, with the monoclonal IL-2 receptor blockers, Basiliximab or Daclizumab, Simulect or Zenipax, or thymoglobulin. And then what happened is he re-injected the blood and did intravital microscopy to look at the adhesion of lymphocytes, which is a normal process. It sticks to the endothelium, it diapedesis, that's how we get rejection, but also, anyway, when I saw this just blew me away. So here is an average, this is what's supposed to happen with control. You see the white cells going through there, sticking. You can even see occasional one kind of leak through diapedes. There it goes, that's in the artery, this is in the vein. And so this is with control. It's doing what it's supposed to do. You get that normal sticking and rolling. Then with the monoclonal antibody, you see the same kind of thing. So you see that guy stuck through their diabetes. And not only do you see them sticking, but they're actually sticking to themselves. And you could imagine that if these get big enough, they would cause an embolus, and it could lead to ischemia. Now, the interesting thing with induction therapy, if you go back to the original Simulect study, where they compared it to placebo, there's less delayed graft function with Simulect. So a lot of people don't realize that. So what's with that? I don't know is a short answer. So this is, what is this? This is Highway 10, on a Monday, Highway 10 on a Saturday. This is something you can't experience here. So this is what with thymoglobulin, and you can see the cars, the cells are just zipping right along, not sticking to that where the rubber meets the road, just zipping along. Maybe this is 10 on a Sunday morning at about 4 in the morning. So you have some of the worst traffic I've ever seen. So long time ago, what happened was I invited 2 people, Ben Cosme and who was the other one? So Ben was sponsored by Upjohn and Tim Schroeder. Tim Schroeder was sponsored by Johnson & Johnson at OKT3. It was at a time when there was a Mideast crisis. I guess there always has been. But at any rate, so the fact that I was getting these 2 competing companies to get sponsored and come in talks, they thought that was pretty diplomatic of me. That was probably my last diplomatic moment. But at any rate, what happened was they talked about this, and Tim Schroeder was working for a company called Sangstat. Not yet. He was at Cincinnati Transplant, and they had the study where they're going to use ATGAM versus thymoglobulin, this new polyclonal for rejection. We got involved in the study, and that was published. But I said, that's great. It works for rejection. But what was neat about it was it worked for rejection, but the problem with rejection is you treated a rejection and then it recurred again. So with the thymoglobulin, it was not only better than the ATGAM, but it didn't recur as often. So it seemed to be there's a more durable and lasting effect. So I went to the company and begged and pleaded, will you let me do this study with thymoglobulin versus ATGAM for induction? And that's the study that we did. And the thing about this, I was young and how to do good studies, it was randomized, double-blind, controlled study. And that's why this is a believable study. And basically what we did is we compared thymoglobulin with ATGAM, 15 milligrams, 1.5 milligrams per kilogram for the thymo, and 15 for the ATGAM. And still, this is how to use these drugs. We held the doses if the platelets were less than 50,000 or the white count less than 2,000, and reduced to half the dose if the platelet count was 50 to 75, and the white count was 2,000 to 3,000. We did not make up a dose, and that's really important too. So what happens is, I think that you can look at your patients, and I say this over and over, you can use your patient as an in vivo bioassay. So when their white count goes down, their body is telling you, I can't take the thymoglobulin, don't give me thymoglobulin. If you give me thymoglobulin, I'm going to have PTLD and CMV and all kinds of bad things. So the mistake is continuing to push ahead and giving this arbitrary 7 days. So when we did the 7 days, we also found out that half the people couldn't tolerate it. Now, we did this study with cyclosporin. That's an old product too, azathioprine and prednisone. And when you see the results, it's going to be kind of amazing here. So the first thing is when we looked at it, there's relatively small numbers of people enrolled, smaller than I wanted to, because the company ran out of the drug. So that was disappointing. And yet, and this was a blinded study, and when I met with them, the head guy, Philippe Pouletti, he wanted me to unblind the study. I didn't want to unblind the study. I wanted to get tenure. So, I mean, so, yeah. So, at any rate, we ended up negotiating, and that led to another study, and I did unblind the study later. So the time to rejection didn't differ overall. The rejection percent did as well. Remember I showed you that SRTR data? This is 1994. So rejection rates were about 30 to 40, 50% at that time nationally. So with us, we got with ATGAM 25%, which was a big deal, but it was 4%. No one would believe it. When I presented this it wasn't the ATC, but it was whatever the equivalent of that was. Barry Cahan was the moderator. He said, "I don't believe you," and I said, "Bring it on." And then other people started doing this themselves. Of course, they didn't believe it until Harvard did it, and then you could believe it. And so I'll show that data here. What was amazing was there was no BAMF3 rejections in either, and the recurrent rejection, not statistically different, but was numerically lower, with the thymoglobulin kind of supporting what I saw. So being at one center for a long time allows you to do long-term follow-up. So we looked at the freedom from acute rejection, and with the thymoglobulin in the yellow, it was 92%, and so then 66% with the ATGAM. So it's important that there's a few late rejections. We really didn't have, we had very few in the thymoglobulin, a few more in the ATGAM. So this was novel, because when I had the IND for that. Oh, that was the other thing. Sengstat wanted the IND. So I went to the FDA, and when I went to the FDA to do this IND, there's a guy there, Charles Mapplethorpe. He was not a nice guy. He's still there. And he just said, induction just seems to delay rejection, not prevent it. I said, I don't know, maybe. But, and so this was the first study that showed that it didn't only just delay it, it prevented it. He also was concerned that I never give the IND up, or that they never use it to get an indication. So I don't know why they're so sticky about that. So that was a freedom from acute rejection. Patient graft survival did not quite differ. This is pretty small. Or patient survival didn't differ, but graft survival did. So that was pretty amazing too at this time, when we're getting five-year patient survival of 85%, which was way better than at the time most people had a one-year patient survival of about 88%. So then we actually went out even to 10 years, and by 10 years still there was a freedom from acute rejection with the thymoglobulin compared to the ATGAM. And that's why with all this, with this small randomized double-blind controlled trial, that ATGAM is hardly ever used in solid organ transplant anymore. At the same time that I presented my data at this meeting, in the very same session, Bjorn Nation presented both the Diclizumab and the Simulect data. So what these are is that they're humanized. So you take a murine antibody, a mouse antibody, you do a chimerization process where you end up here getting human IgG. The idea behind this was that by making it humanized, you're not going to develop antibody to it, and it's going to neutralize it. Because in the old days, OKT3, the name of that was Miromonab, which is murine monoclonal antibody, Miromonab. And you could make antibodies to the murine portion and neutralize it. But the thing for induction that I never got was, well, it takes 6 weeks to develop these antibodies. So why do you really care, at least for a first-time, Greg, rejection if you're using Simulect? Now, you also have to understand that when I went to the Brigham for my fellowship, that my project was something called Targeting the IL-2 Receptor in Diabetes. So what this was doing a prototype of Simulect, Zenipax, and looking at its role in autoimmune model mouse, NOD mice diabetes. It didn't do bupkis. So I really had kind of a jaundiced view about the stuff to begin with. It didn't make sense to me, and there was also out of France, Jean-Paul Soulou had done a very early heart transplant study with the IL-2 receptors. At any rate, so this is the data, and I just want to back up a minute and look about this. We talked about this this 5-year event-free survival rate. Actually, we have 5-year graft survival. 5-year freedom from acute rejection, 92% versus 66%. So by 5 years, an 8% rejection rate. This is in the Simulect US trial. This was championed by Dr. Cahan, who was in Houston. Now, the 6-month rejection rate was Simulect compared to placebo. So first of all, what you see is rejection rates at the time, and the 1-year rejection rates were 41 versus 59%. Remember what I said early on. What was the rejection rate that we normally expected to see? It was around 40% or so. So yes, this is statistically significant, but there's an aberrancy. The aberrancy is that in the control group, you had a much higher rejection rate than compared to historically. So that's the thing. And when you look at graft survival, it's pretty good. Event-free survival, which meant freedom from rejection, graft loss, or death, was better, but really not good. And so that was the problem. Then when you looked at the Europeans actually had done a no induction versus thymoglobulin with tacrolimus or Neoral, because remember at the time, people are using cyclosporin. Let me just go through this a little bit. And I present this slide because there's been a meta-analysis, but no one believes meta-analysis, that showed that induction therapy was better than no induction therapy, and for basically all comers, except the 2 haplotype living-related white people, which we're trying to get that, pull the data together and publish it because a lot of people don't believe that. At any rate, you can see with tacrolimus that the rejection rate was with Prograft versus Prograft thymoglobulin, much benefit, 23%, and biopsy-proven acute rejection was 15%. Because at the time, the creatinine would go up and you'd give them steroids. And then you'd get a biopsy. That's not the way we do things. Now we biopsy first, usually before we treat. And with Neoral, it was 37 versus 21%. Kind of pay attention to these numbers here, because this is going to come up over and over in some of the studies that have been done now. And this was steroid-resistant rejection, which is this was before we had the concept of antibody-mediated rejection. So steroid-resistant rejection would be those that required antibody for treatment. So think of that as kind of a surrogate for AMR. So then what we did is, with this, went to Sangstat, convinced them to do a study which would compare thymoglobulin to Simulect for induction therapy and transplant. There was a multi-center study. It involved the 17 U.S. sites and 11 European sites, and the company kind of goofed. They decided they wanted to go for a quadruple endpoint. At the time, the FDA had a triple endpoint, which was freedom from rejection, graft loss, or death. Now, the FDA adds what I think is a statistically important thing, loss to follow-up, because loss to follow-up should be thought of as doing bad. Sangstat at the time really believed in the concept of this could prevent delayed graft function. And so they put that in there. And as you're going to see, it kind of came back to bite them, because the FDA, even though they were superior on the triple endpoint, because they had said they were going for a quadruple endpoint, the FDA said no indication, so thymoglobulin is not approved for the prevention of acute rejection in the United States. It is throughout the world based on a lot of these studies. Now, we shortened the duration down from 7 days to 7 doses to 5. I wanted to go for even lower, to 4 or 3. But when you're dealing with other people, you have to compromise. I hate that. So these are the endpoints that you get. So you can see the quadruple endpoint, not different. Triple endpoint, P equals 0.02. Would have gotten their indication. And it was almost all driven by biopsy-proven acute rejection. Graft loss, death didn't differ. Delayed graft function didn't differ. We're going to focus on this because there are some aberrancies. So one of them was the French people had been using thymoglobulin for 25 years, and you couldn't tell the French that you need to give it in the operating room, because we think, nope, they weren't going to do that, and they didn't. And so that kind of might have affected the study. So it turns out that thymoglobulin was associated with a 39% relative reduction in biopsy-proven acute rejection. So this bar graph you can look at in kind of 2 ways. You can look at it in yellow versus red, thymoglobulin versus Basiliximab, 16% versus 26. Or you can look at it this way, red versus red and yellow versus yellow. So if you were randomized to thymoglobulin, 16% of the people got acute rejection, but of the total, only 1.4%, less than 10% of the people who got thymoglobulin ended up needing antibody rescue for their transplant. However, if you had got Basiliximab, Simulect, 8%, so almost a third of the people ended up having to have a rescue therapy. So if you don't use it for prophylaxis, you're going to end up having to use it for treatment for acute rejection, and the dose and duration is about double. There are side effects with the drug. So basically, the white count is low, and then you can see here, but it rebounds right away by 2 weeks, so that it wasn't of serious consequence. And if you actually follow it and don't give them the extra doses, it's usually not of major consequence. Thrombocytopenia occurs too, but look at the level. It's generally not like, in the 20,000 range. It drops to about 100,000, not clinically significant. And then it rebounds again here by post-op day 14. So when you look at adverse events, everyone with thymoglobulin would think, oh, you're going to have more viral infections, you're going to have more CMV, more BK, etc. In this study, first of all, when you look at adverse events, almost everyone has an adverse event. So when you see a study where they say their adverse events rates were 20%, something's wrong. Because, nausea, everyone's got nausea, so that's an adverse event. So serious adverse events too, almost 3/4 of people have a serious adverse event. So, but it didn't differ. Leukopenia did differ, but that might be an effect as well as a side effect that might be beneficial to prevent delayed graft function, etc. All infections were increased with thymoglobulin. Important point. So thymoglobulin, rabbit ATG, is a potent immunosuppression. So what I like to say about it is not only does it allow you to use less immune suppression, it pretty much mandates that you use less immune suppression. So malignancies didn't differ here. There's actually 3 people that had PTLD. Actually, 1 didn't have it within the confines of the 1-year study. It happened more than 13 months out. I said, I don't care. My name's on the paper. I know that this happened. Fess up. There is an increased risk of PTLD with thymoglobulin. You just have to know how to prevent it. So the other thing that's important is antibacterial prophylaxis was used less commonly in the thymoglobulin, 18.9% versus 30.9%. And we look at the infections. When we looked at urinary tract infections, the differences might be in part because you didn't get antibacterial therapy. So at our program, and we just had a paper published, we use Bactrim indefinitely for people. And so just when I thought I was going to get rid of Bactrim, there are these reports out of England, France, and Australia that PCP is on the rise. So I never have to worry about PCP. But we also noticed that when you use Bactrim, that the UTIs tended to be less, but sepsis, requiring hospitalization, was definitely less than the people who got Bactrim indefinitely. So that's what we do, and we use a lot of thymoglobulin. Surprisingly, CMV was less. Now, I tried to go back at the case report forms and figure out exactly why. The closest thing I can see is that probably the people who had rejection, got more steroids, didn't get restarted on their, at that time, oral ganciclovir for antiviral prophylaxis, and they ended up with more CMV. This has been seen in a couple other studies, but not every other study. Fungal infections, protozoal infections weren't different. Fungal infection here was usually candidiasis. And again, steroids were a lot higher in those days than they are now. Malignancies didn't differ. I already talked about the PTLD. One of the keys to the management and prevention of PTLD, if you don't believe a word I said about induction, this is something else I care about, CMV. So this is a study. This was done by Donnie Funch, and basically this was a time when MMF was coming out. And what they were concerned with MMF is that everyone was concerned that it led to more CMV, which it does, and more PTLD, which it might not but it's not because it wouldn't normally, but because people started using prophylaxis. And this is looking at where they did is they took 100 PTLD patients and matched them to 375 controls and showed that for every 30 days that you were on acyclovir, there was a relative reduction, so odds ratio of 0.8, so a reduction of 17% in developing PTLD. And for every 30 days that you were on ganciclovir, the rate was 38%. So what this means is you got to give prophylaxis, to antiviral prophylaxis, to prevent PTLD. So what Angelina knows is that in our positive and the negatives, I think I have we actually give 9 months of Valcyte. In positive positives and negative positives, we give 3 months. And then for our negative negatives, we give acyclovir, 200 milligrams BID. And our PTLD rate is very, very low, despite the use of thiamoglobulin. So this is one of my favorite studies that I've ever done that has been cited all of 9 times, and one of it was we cited ourselves. So, and we just tried this, we just did submit the 10-year study, and they said, well, you've already published this isn't novel, so I'm going back. They said also it's irrelevant because people, you use cyclosporin. Well, surprise, the rest of the world actually does use a lot of cyclosporin, and still, so I think it's relevant. And I also think that's novel because even though this was in the New England Journal, they made me reduce it to a long letter. It's about a 2-page letter. And I did that because I was young. I still wanted tenure, remember? And so I thought a New England Journal letter was better than a AJT full manuscript. I might have been wrong. So what happened is this was looking at the original study, 278 patients, 183 of them were US, and 160 patients exactly matched to the OPTN records, 23 weren't, because there was things where they goofed up the date of the transplant, a couple days, because they wrote it down wrong or it happened at midnight. 10 patients were unmatched. We tracked them down. We tracked every single one of them to their HLA and could get their rejections. And we could get whether they're alive, they're dead, what their creatinine was, whether it had their rejection. This is so important because now the rest of you guys are dealing with the horror of REMS, right? And first of all, how many people fill their REMS forms out? That's what I thought. So what happens is I'm trying to point out that this is a way in transplant we can track the long-term effects. And this can be good whether we're tracking Bella or Eculizumab or MMF. All these things that we're supposed to fill out. The REMS, by the way, is a risk evaluation mitigation strategy that the FDA said the companies are supposed to ask doctors to fill out these forms. And I want to fill out another form. I can't wait to wake up in the morning to fill out another regulatory form. So this is looking at what Mark Schnitzler and I showed. So again, looking at thiamoglobulin and Basiliximab, the freedom from acute rejection in that study remained better. Death-censored graft survival was better. Remember, you didn't see it, and the freedom from the triple endpoint was still different at 5 years. So that's what's important about this. Again, that Charles Mapplethorpe, when he challenged me, induction therapy, he said, only delays rejection. It doesn't prevent it. Well, this is long-term evidence that not only does it delays it, it prevents it, and the thiamoglobulin is better than Basiliximab. Now, one of the things that the KDIGO said, remember, when I started out this lecture, was KDIGO should be used in, quote, high risk. So what's high risk? Well, ECD kidneys, are they high risk? DCD kidneys, are they high risk? Again, I think high risk is high PRA, second transplant. It doesn't matter whether you're black or white, because in France they got black people and they do just fine. And so there's something else that's going on there. But we went and looked, thinking that thymo would have a bigger bang for your buck in the ECD kidneys. We found just the opposite. That thymo's biggest impact was in the recipients of normotensive standard criteria donor kidneys. Remember, the quadruple endpoint didn't differ, triple endpoint did, not biopsy-proven acute rejection did. Now we see even a little bit bigger difference. Graft loss was a tendency to be higher. Again, this is a lot smaller N, but death was in fact statistically lower when you use thiamoglobulin for the normotensive. As you guys know now at the KDPI, we're getting a lot of bad kidneys anyways. But hypertension is just really bad. It's in a kidney transplant. So the other thing is people say, well, we can't do this. Well, we have to worry about costs. So Mark Schnitzler, actually what he really is an economist who happens to love transplant and statistics. So he showed that basically by day 7, thiamoglobulin was associated with a $4,000 savings to Medicare. So and by day 365, a $7,600 savings to Medicare. So what's important about this is when you think about Medicare, if you think about charges, you basically multiply it by 10. So for instance, what's a CVC reimbursed with Medicare? Anyone know? It's about $11. So what does Barnes charge? They charge about $110 for that. So what does the Medicare reimburse for a CMV test? It's about $56. What does Quest charge you for a CMV test? It's about $500. So that's the difference on FK level. So we want to save money. We can stop getting FK levels on post-op stay 1, 2, and 3 because they're $450 and Medicare reimburses about $50 for that. Any rate, so it turns out that this would be what would be called a dominant therapy. It's both better medically in terms of outcomes, but in terms of cost. This has never been published, but Mark was able to do this and look at the cost of transplant in all the centers. Actually, you can get this for all the centers. And that's why he can't publish it, because he knows what he knows right where Northwestern fits in there. He can find out where you guys fit in there. But Eggers and those guys don't want us to publish that kind of stuff, especially on the center level. But what you can see at the top, well, first of all, let's look at the bottom. This is the cost of transplantation at Barnes when we're using thymoglobulin. So you see in the first year, this is about 20, starts at 20,000, goes to up to around 40,000, but it is relatively slow increase compared to the others. Up here in the top in the orange and the yellow is the U.S. cost of no induction, and the U.S. cost of other induction. Here is the U.S. cost of thymo for other centers other than Barnes. Have to remember we're also using a lot of azathioprine when the rest of the world was using MMF. Azathioprine cost $600 a year. MMF was costing $6,000 a year. It doesn't now with the generic. And you can see now the cost here in maroon of co-stimulatory blockades and of Xenopax and Simulect in here, right in here, so that if you're looking at a cost to Medicare, this is huge. This can save $50,000 from not using induction to using induction the way that we did. The other thing is we talked about low risk. Well, this is a study, we actually looked at this. So we had been using thymoglobulin in our living donor, living related and living unrelated recipients, and then basically we compared outcomes with the to national data where they weren't using induction, and we showed that our survival, a little bit different, was better in the living donors, about 96% versus 93%. Probably a better study, or maybe more convincing study, is the University of Michigan was in their living donor recipients, or their living unrelated kidney transplant recipients, was using no induction, and they decided to use thymoglobulin induction. And you can see here's what their rejection rate in living unrelateds, again, quote, low risk living donors, was 40%, but when they went to thymoglobulin, it was 2%, 48% versus 2%. You also have to understand that Michigan, until about 2 years ago, was a cyclosporin center. CMV different malignancy, graft failure. They said costs were lower with the no induction, but they didn't pay attention to the fact that they didn't take in the consideration the costs of rejection. And if you've ever even done a biopsy or seen what the charges are, a charge for just getting a biopsy is around $6,000. We think that there's nothing to it, but it's pretty big. So it's always nice when you've done a study and someone that kind of validates it. And so this is a French and Belgian study. Again, they couldn't kind of follow what we wanted to do in the original thymoglobulin Simulect study. They decided to compare, and remember that was on a cyclosporin background. This is on a background of tacrolimus, very similar. It was a randomized multi-center study, almost the same number of patients. Little bit high, quote, higher risk. Current PRA averaged more than 30%, peak PRA greater than 50%, and they had a previous transplant. The mean cold ischemia time was 23 hours, and more than 50% died of a CVA. So these are ECD kidneys. And they randomized them to either thymoglobulin or to diclizumab, but they actually did give it in the operating room. And so with that, what they found right here was that delayed graft function was lower if you gave thymoglobulin in the operating room compared to giving daclizumab. So acute rejection, remember what we showed in our study with cyclosporin? So maybe these are a little bit high risk, but it was 16% versus 26%, same thing. Time to rejection, I didn't focus that on our study, but actually this should be 12 days versus 35 days. Severity of rejection, antibody, the requirement for antibody-mediated rejection, 2.7% in the thymoglobulin study versus 15% in thymoglobulin recipients versus 15%. So again, showing the same thing that we had shown in another multi-center study. CAMPATH. So CAMPATH came along shortly afterwards. It had actually been kind of developed by Herman Waldman and Sir Roy Kahn in England. It's an anti-CD52 antibody. The way you remember this and the way this was presented at the transplant meetings, they referred it to as the B-52 bomber. So, and because it wiped out all the T and B cells. Now, I didn't think that was such a great analogy because I grew up as a kid in Vietnam and I just kept thinking of B-52s in Laos and Cambodia and wiping out all those innocent civilians. So I didn't think that they should really be using that analogy, but Stuart Connectley liked it. So what this is, it targets the CD52 antigen. Anyone know what the CD52 antigen does? Well, if you do, please let us know because no one does. At any rate, I don't know why they came up with it, but this is what Dr. Waldman and Dr. Kahn decided we should do. And this is probably the best study of alemtuzumab induction or CAMPATH induction, and it's not such a great study. It's called the INTAC Trial. It's alemtuzumab versus thymoglobulin in high risk, which was people with a higher PRA or happen to be African Americans. Again, very arbitrary term. Alemtuzumab versus basiliximab. Okay, so we've got we've got high risk and low risk. We've got alemtuzumab and ATG. We've got basiliximab, so we've got 5 different variables. Okay, and all patients got TAC MMF with a 5-day pred taper to off. Okay, so the reason this is a bad study is if you've ever done studies, you try and compare one thing to another, thymoglobulin to ATGAM, thymoglobulin to Simulac, and have everything else be the same. You don't compare high risk, low risk, high-risk alemtuzumab versus high-risk thymoglobulin, low-risk alemtuzumab versus low-risk basiliximab. Again, high-risk, PRA greater than 20%, retransplants are African Americans. So what did the data show? So this is the biopsy, now biopsy confirmed acute rejection rather than biopsy approved. One of the big investigators, this was Steve Woodle, and what he points out with, now they're lumping them together. Now they said, okay, we'll just lump them together as conventional therapy. Well, in transplant, there's not so much conventional, but you can see with conventional therapy that the rejection rate ends up kind of plateauing. But with alemtuzumab, it really doesn't. And if you blow this up, this is one of the biggest concerns with alemtuzumab. I know you guys aren't, at any rate, that it wears off. I don't know whether you're CAMPATH users or not.
We are.
You are. So this is one of the concerns. The major reason to use CAMPATH, I think, is that it's a single dose, it's peripheral, the reasons, and right now it's free. So those are the main things. So and there haven't been head-to-head comparisons of, say, thymoglobulin with CAMPATH. And you know, it would be hard to do because Sanofi owns both drugs, and they don't want to do it. So, and you know, they wanted to get their indication in MS, and that didn't work, and so we're still left with, you guys can get it, but since we weren't a CAMPATH center, it's hard for us to get it. It's hard to even get CAMPATH on the oncology side. So when you look at the percent of patients with biopsy-proven confirmed acute rejection at 3, 5, 13, 17, 20, again, kind of pointing out that it does show, similar to what we said, a potent anti-lymphocyte depleting antibody like CAMPATH or thymoglobulin is going to be associated with rejection rates that are fairly low, but here's what I mean. So you went from 15 right away with conventional thymoglobulin, or not thymoglobulin, basiliximab, or no induction, and then to 17 at 12 months, and then not much late rejection here, but a significant number of late rejections in alemtuzumab, where it kind of wears off. So when you looked at the again, this is looking in the high risk. Most of the rejections differences came in the low risk with the alemtuzumab. Again, so that's kind of confirming what we said with the thymoglobulin, right? Your biggest bang for your buck is not in your high-risk patients, but actually in your low-risk patients, whatever those are. So again, this is kind of looking at the patient survival of this. This is alemtuzumab, rabbit ATG, and in the X is rabbit ATG graft survival. This turns out this was not statistically different, but you're comparing apples to oranges. You know, it can't be done. I don't know where the statistician was on the review of this. Any rate, the conclusion of the INTAC trial is that in high-risk groups, alemtuzumab and thymoglobulin had similar efficacy, but alemtuzumab seemed to wear off. In a low-risk group, alemtuzumab provided superior prophylaxis of acute rejection, less need for antibody treatment, and no increase in infections compared to basiliximab. And then, that still seemed to be wearing out. One of the big things is induction therapy, and this, again, I told you that Donnie Funch study was, I think, one of the best studies, important studies for prophylaxis of CMV. This is one of the best studies done for argument, in my interpretation of the data, argument against steroid withdrawal. So this is a randomized, double-blind, placebo-controlled study of 5 years duration. There's nothing like it in transplant. It's awesome. Unfortunately, Steve Woodle, who I know, I think misinterpreted his data. And so let's go over that and why I think that. So this is why. So the biopsy confirmed or acute rejection rate was 60% higher with corticosteroid withdrawal. So remember, this is randomized, double-blind, placebo-controlled study. They withdrew steroids by 5 days. They had a long taper down to 5 milligrams, but they didn't get down to 5 milligrams on the steroids till like 6 months. So very different from what we're doing. We're down by a month to 5 milligrams. So keep that in mind when you look at the side effects of corticosteroids. At any rate, the rejection rate was 27.3 versus 17%. 27.3%. Wow. And this is with, actually, let's see what it was with. This is with mostly thymoglobulin. So what they did say is that your rejection rate, if you got RATG, which is the red is a corticosteroid, yellow is a corticosteroid withdrawal, that there was no statistical difference, that the biopsy-proven acute rejection rate was 14% with thymoglobulin and 24% with the IL-2 receptor. So almost two-thirds of the patients, more than two-thirds of the patients, got thymoglobulin induction. So what this says to me, if you're going to try steroid withdrawal, you need to consider using potent anti-lymphocyte therapy, and this study used thymoglobulin. But still, with that, the 14%, that's about what people were getting, maybe, you know, with the thymoglobulin, as you've seen in our study, in the French study, now in the Steve Woodle study. That's about the kind of rejection rates you get with thymoglobulin. So, and probably what it looks like what you're getting at about 1 year, maybe with alemtuzumab, but there's late induction. So, in adequately powered randomized controlled trials, induction therapy with anti-lymphocyte agents results in less acute rejection, better long-term survival than IL-2 receptor blockers. I didn't show this. In meta-analyses, induction with anti-rejection results in less acute rejection and better long-term survival than not using induction therapy or basiliximab. And induction therapy with anti-thymocyte agents increases the risk for CMV. Appropriate prophylaxis should be used. Whether or not ATG is superior to alemtuzumab, to me, is unclear from the current randomized controlled trials that we have. So thanks for your attention. That was a lot of information in a short time, and it's here for you, and there's more stuff on optimizing induction with control of BK and CMV, which are the other things that I do. So thanks for your attention. Preguntas? Yes.
Thanks for the great talk. I'm a pediatric nephrologist. So if you're doing thymo as an induction and booster withdrawal, do you think compared to basiliximab, do you think increase risk for infection and PTLD in pediatric population?
So I think that, so the question, in case you all didn't hear it, is using the thymoglobulin in pediatrics, especially with steroid withdrawal, which by the way I don't advocate even in kids because the rejection rate is higher, and rejection will stunt your growth a whole lot more than 2.5 milligrams of prednisone. But at any rate, if programs do that, and most pediatric programs do, that if you use thymoglobulin, the question is, are they at greater risk for PTLD? And the what's left unsaid is, yeah, because they tend to be EBV seronegative. So they are at greater risk. So what happens is, in the adult population, and the pediatric guys have come mostly rotated through with me over the various years, and I mentor a couple pediatric transplant nephrologists. At any rate, what I try and tell them to do is use again cyclovir prophylaxis for a long time. So like I said, we do it 9 months in the positive and negative. Where does that come from? Well, we've studied everything. We've studied preemptive versus prophylactic. We've done 3 months, 6 months, a year. We go to 9 months. We go to 9 months because when we had it at a year, then we start getting labs. Instead of every 2 weeks, we start getting labs once a month. Instead of following up in the clinic every 3 months, it's like 6 months. And so what we were finding out is they would get labs and the CMV had already happened. So if we're following them in the first 9 months where we get labs every 2 weeks, I see the white count drop from 6 to 4. Okay, it's not dangerously low, but I saw it, and we've trained our coordinators. This is lower. The platelets might go from 250 to 150. They're not low yet, but it's a sign. So, at any rate, then after that, we give the long-term EBV prophylaxis. There's one study I can't quote you from in peds where they were trying to give EBV prophylaxis with a cyclovir to prevent PTLD in kids. I don't think it worked, but I think it wasn't a lack of efficacy. If the kids take their drugs, that's the problem. The kids don't take their medicines. So I think this is a strategy to try. But as far as I know, the last thing probably published 10 years ago, it didn't work.
Just a quick, we are not a pediatric steroid withdrawal program.
You are not?
We are not.
Oh, good. Yeah, I would, festina lente, hurry slowly. That's Latin, so don't go rushing into that. Let the other lemmings jump off that steroid-free cliff, you know.
But then I guess in the past, you sent us some published papers on these transplant use. You studied the using of these steroid withdrawal.
Yeah.
And the rejection is the same. The PPR rejection is still the same. The difference is that it releases the and then it's better for birth. Birth is much better with steroid withdrawal. And then it had one of the biggest risk for steroid use.
Yeah.
I thought
So I'm familiar with that, but not in the depth that I am with the familiar enough to know that when I read that, the steroid withdrawal was too long, too late. So it's not what is being used now, and so I think that's a big deal. I think one of the things that Art Manis and all the steroid-free people have done to the field is accelerated the steroid reduction. I think that's really important. But getting rid of them, I mean, there's more fibrosis on protocol biopsies in the steroid-free. Oh, I didn't show the chronic rejection rate, whatever that is, was twice as high in the steroid-free. And remember, Woodle said, that's because we biopsied people more often in the steroid-free. Well, it was a double-blind placebo-controlled trial. You biopsied them because their creatinine was up, because they had more problems. So again, be careful, I mean, I'm 5'7". I did okay, Yes. Yeah.
But I think at the beginning you mentioned that for truly low risk, like a well-matched donor recipient, you can have a protocol.
Yep, and we've been doing that for 20 years. To reiterate, so I think there is only one truly low-risk group that you can say that, and that's the immunologically gifted 2 haplotype white people. Why do I say white people? Because actually Ojo at Michigan years ago, like in 1993, did this study where he looked at rejection rates in 2 haplotype matched white people versus 2 haplotype matched black people. And the 2 haplotype matched, and remember, this is not zero antigen mismatch. This is sibling to sibling 2 haplotype matches. So now part of the problem is that's an old study where our definition of the HLA was not as accurate. So there's a 25% DR error rate, or in the old days. Now it's all molecular, so there really isn't. Any rate, so what we do is we do not give any induction therapy for our 2 haplotype matched white people. Actually, it turns out we do because there's screw-ups, but usually when I come on and stop that madness, and then we get rid of the calcineurin inhibitor between 6 months and a year usually.
And you use nothing, but not similar to use.
No, nothing. So now, so what our protocol is basically thymo for everyone unless it's contraindicated, except in these things. 2 haplotype matched living relateds, someone who comes in with thrombocytopenia or leukopenia. It's just too dangerous, or someone who comes in hypotensive. So, and actually that's a group to really be afraid of. The fat hypotensive person on midodrine is going to have primary non-function. So we're trying not to do those any longer. And then if you're getting a kidney liver, so I would use nothing but our surgeons, I created a monster, so they want to use induction, so they will give Simulac, and it's close to water, but expensive water, or it's a Shirley Temple, or we have other things that we say about it. At any rate, they feel comfortable giving the Simulac in the kidney liver, or say we've got a person who has had heart or lung and they're coming in for a kidney now afterwards. They've been on immune suppression for years. What we did, I noticed this with the heart, the lungs. We gave them thymoglobulin, and what happened was they died. They had infection, and part of the problem. Do you guys do lungs here? Yeah. So lungs are tough, and I don't know about your lung transplanters, but I mean, they just slam them with immune suppression. And so from the little part that I could do, we changed them to Simulac, because I went back to UNOS, and we had a higher death rate than I thought we should have. It didn't reach the cutoff, but I looked, and they were all lung transplant patients getting a kidney afterwards. So, yes.
Great presentation. I have 2 questions for you. So for the final dosing, once that leukemia starts, do you stop it and not give any additional?
Exactly. And so our dose, by the way, so you've seen the different doses. What is the right dose? So Bill Goggins did a study in which he randomized people to at Boston, intraoperative thymoglobulin versus postoperative. If he gave it intraoperative, the delayed graft function rate was way lower. He also showed in that study that the only people who had a rejection got less than 3 milligrams per kilogram. So I think 3 milligrams per kilogram is probably the lowest you should go. And then I don't think you really need to go higher than 6. We actually are giving 5 now. I've reviewed everything on this. Some people are using 4.5, some 3. We've looked at various strategies, giving 6 milligrams per kilogram all at once in the operating room. We did that. There was more cytokine release, probably. I couldn't prove it statistically, but it wasn't worth it. It didn't get him out of the hospital any sooner. So then we had also done, with Irfan Agha, we had done a 3 milligram per kilogram starting in the operating room. And when you give that big dose, you got to give it over 12 to 24 hours. So, and then 1.5. And then now what we give is we give 1 milligram per kilogram in the OR starting before reperfusion, and then give 2 milligrams in post-op state 2 and 3. And if there's leukopenia, usually if they're coming down, the first thing we do is stop the MMF or the myfortic.
The other question I have is regarding the cancer. On the INTAC trial, we have a trend with more rejection for years. Is there additional data available beyond that to demonstrate?
So the question that Neem is asking is, there is additional data beyond the INTAC trial looking at late acute rejection. And there's more than a few single center studies showing there is late acute rejection and tends to be vascular rejection. That's the concern. Now, just down the road is, Francis Wright, who's been using all this CAMPATH forever and writing about this. But talking to Irfan, the problem is long-term follow-up. And it's hard because we're a center that follows every person till they die or return to dialysis. We really know what's going on. They don't. They send them back to the private nephrologist. They don't know, so you don't really know what the long-term results are. Northwestern, the other big CAMPATH, they discharge them on post-op day -1. And then, because that's the most business, that fits into their business plan. And so, no, but they don't have long-term follow-up. So they don't know. Wisconsin did. Now, Wisconsin had long-term follow-up, but the problem with Wisconsin was they were giving it with Rapa, another not very good drug, and they were giving it with lots of steroids. And so they had, my former partner, one of Angelina's mentors, Christina Klein, was at Wisconsin, and she called them the VOC, right? Not the Viet Cong, but the victims of Campath. So they had all these horrible infections. Yes?
Another question regarding that, I was in touch with his dose and kind of what he's starting to get more detailed.
Yeah, that's not so clear. There's actually, thymo hasn't been really looked at it quite in that way. OKT3 was, ATGAM was, and it's actually around 10 milligrams. I would think it would be closer to around 10 milligrams per kilogram. So it brings up another thing. So with rejection, what's the dose? Well, in the original ATGAM versus thymo for rejection, the average dose was 10 milligrams per kilogram. Most people have already, in our program, already gotten 5. I don't feel comfortable giving them 10. So I usually will give them somewhere between 3 and 6 milligrams per kilogram for treatment of rejection, so that in a year's time. What's our antibody-mediated rejection rate? We just looked. So our antibody-mediated rejection rate is 1.7% at 1 year and 2.7% at 3 years. So, and the early rejections are probably those people who had a cross-match, we do cross-match positive. We find them actually retrospectively when they've got a positive, usually it's not a CDC positive cross-match, but a flow cross-match. And then people who stop taking their medicines are the ones who get the antibody-mediated rejections. Yes?
Well, I should say that. BK you brought up.
Yes.
Do you have criteria for how you define your high-risk BK population and what's your infection?
So the question is, do we have a criteria for high-risk BK, and what's our induction therapy for that? I thought I had it in this slide, but I didn't. So in our study, we actually looked at the incidence of BK among those who got in our which study was that? The FKBK study. That was the FKBK study. So like I said, we don't use thymo in our 2 haplotype matched people, and that was a study of tacrolimus versus cyclosporin. So 12 people didn't get induction therapy. The difference in BK viruria and viremia did not differ between those who got thymo or did not. So we give it. If you look in the literature, thymo, they say there's more BK. I don't think so. There is more CMV, I think, with thymo, despite that New England Journal study that we did. I think it causes more CMV. It doesn't seem to do that with BK. So how do you define someone high risk for BK? Well, first of all, you could go ahead and get titers which are available through Viracor in Lee Summit, Missouri. It's probably not worth it, because what we showed is that the higher the BK titer in the donor, the more likely the recipient is to get that. So you can do that preoperatively in living donors. You can get it late, but you won't get the information. There's no drug available. There's a drug that works against CMV or BK. It's lipid conjugated cidofovir, but it's not available. So just cutting to the chase, there is no role for IV cidofovir, leflunomide, or quinolones. There's an unclear role for IV IgG for management of BK. But for those other ones, paper is soon to come out will show definitively, especially that no role for. So
just for historical perspective, since no one talks about history of transplant much ago, Ben had his stable outside of Mass General, I think in Lexington.
yeah.
And Ben was here and had a stable across. He was in the Air Force here, during the very fun stuff.
Okay.
And had a stable at Lackland, and he was making his own background for the Air Force then. He still always teaches about batch-to-batch variability.
Right.
Which I think still existed in AFGAN when we were using it.
Yep.
But went away, correct me if I'm wrong, with thymo. You're not supposed to see a batch-to-batch variability.
Right. So what Greg's referring to is that the batch-to-batch variability that we had with ATGAM. And the reason is they had 3 horses. So that's it. So it could vary with how well the Freund's agent. They use hundreds of rabbits. So, and they pool all of it, and that's why there's less batch-to-batch variability.
Thank you. I had a couple of questions, Dr. Brennan. Excellent presentation. My first question was about the late antibody-mediated rejections that we're seeing with the INTAC. And my question is, do you think if they were not in a steroid withdrawal protocol that would make any difference whatsoever? Do you think that steroids have any role in preventing late onset?
I do think that steroids have a role in preventing late onset rejection and even antibody-mediated rejection. They're one of our most potent B-cell drugs that we have. So I think that's pretty clear. I think the Woodle study shows that as well. I'm trying to remember the details on the Wisconsin studies because they were messing around with a lot of things, but I don't think they were getting rid of steroids. But they might have been when they were using RAPA. And so that might explain part of the late antibody-mediated rejection as well.
And my second question is about your CMV prophylaxis for those on FIMO. So we've been discussing our protocols, and so we were asking Dr. Edwards, 9 months, where did you get 9 months? You know, the only data we have published is 6 months. And so the problem is it's very difficult to get insurance companies to approve it because there is no indication, beyond 200 days for Valsite. So my question is, why don't we do a prospective trial to show that, if maybe there is benefit in kidney transplant so that we can get funding?
Well, that sounds like a good idea. Yeah. I mean,
You, not
me. Yeah. Who's we, Kemosabe? Me and the toad in my pocket.
But that's probably the most expensive medication that we use for maintenance therapy. And
Yeah.
it's really difficult for us to get.
No, you're right. Our social workers struggle with that all the time. So, and we've also, so when we can't get the drug paid for, we use our preemptive approach. And we've published on that, and we published that both are equally cost effective. You don't get late CMV when you do preemptive. It all happens early on. And what's interesting in our study, Jad Curry was the first author. He's an ID fellow. In the positives and the negative, only 54% develop CMV in the first year, measuring viremia weekly for the first 16 weeks and at once 5, 6, 9, and 12. So it shows that there's like half the people don't, even in the high-risk CMV group, don't need Valsite. But it's a pain on your coordinators and everyone else to do that. So it probably should be done. Yes.
Actually, I had
Okay.
So can you talk a little bit about how you guys monitor the T-cell subsets, or do you just
Yeah.
look at the total white count when you're trying to decide whether they're
We actually look at the absolute, so the question is, how do we monitor the T-cell subsets? So in the old days, we used to look at CD3 and CD5. Remember I said CD5 was on it's on T cells, all the T cells, but it's also on B cells. So with ATCAM, we used to see that actually the CD5 count didn't drop. So we see, when we first started using THYMO, I think I published this. Might have been an Irfan's paper, the long-term, the follow-up of the 3 milligrams, 1.5, and 1.5. Yeah, I think it's buried in there. We looked at CD3 and CD5. At any rate, we stopped doing it because the absolute lymphocyte count is free. It's part of the differential, and it's always 0 in the first few days. Now, what we have tried to do is, I've used it clinically, and sometimes you do things clinically on what you think makes sense, and then we're trying to prove whether it's true. So I see an absolute lymphocyte count of, we know long-term that a third of our patients have an absolute lymphocyte count less than 700. Pretty darn low. 2/3 are less than 1,400, and a third are higher than that. So 2/3 of patients long-term after thymoglobulin induction have what would be considered a subnormal absolute lymphocyte count. We actually use that to feel comfortable with that. That's why on post-op day 5, our MMF or Myfortic is 500 BID, 360 BID, and 60% of our people older than 65 are only on dual therapy with tacrolimus and prednisone, and 40% overall are only on dual therapy. So we tried to look at the absolute lymphocyte count because the French keep writing about if you have a low CD4 count, you're going to get squamous cell cancer and all these. There's this guy Cusi, C-O-U-Z-I. Any rate, we've looked. We can't find that the low lymphocyte count is either beneficial or harmful. Any rate, we kind of look at it as part of, it's on our flow sheet, on our overall approach to the patient. I can tell when someone got Simulect induction because I'll look at that and see they've got an absolute lymphocyte count of 2,500. And then I'll say, whoa, what's with that? And then I'll go back and say, yep, sure enough, they got Simulect induction. So it's cheap. You don't need to get the flow cytometry. All righty, well, thank you very much.